Good afternoon. I'm Evelynn Hammonds. I am professor of the history of science and African American studies, and also director of the project on race and gender in science and medicine here at the Hutchins Center for African and African American Research at Harvard University. So welcome to the conversation today. This is the fifth one that I've been hosting with leading scholars in public health, the history of medicine, and African American studies. And we've been talking about the historical and contemporary impact of epidemic diseases on African American communities in the United States. So welcome, thank you all for joining us. Let me just give a few introductory notes about the conversation. All the participants will have muted video and microphone during the conversation. There will be a 15-minute Q&A after, and please post your questions using the Q&A button on your screen. The slides and recording of the conversation will be available in about a week on the website. And afterwards, after the conversation, please also continue to send questions to the email listed on the screen. Also, at a later point, suggested readings from each of the conversations will be also available on the website. Just another note to remind you about the Q&A during the conversation. The chat function is for comments between participants only. And during the Q&A, the last 15 minutes of the conversation will be use the Q&A function for short questions for the speakers, myself, or Dr. Farmer. Thank you. So I'm very happy today to have a discussion with Paul Farmer on infections and inequalities. Paul Farmer is the Colocatrones University professor and chair of the Department of Global Health and Social Medicine at Harvard Medical School and chief of the Division of Global Health Equity at Brigham and Women's Hospital in Boston. He is co-founder and chief strategist of Partners in Health, an international nonprofit organization. Dr. Farmer serves as the United Nations Special Advisor to the Secretary General on community-based medicine and lessons from Haiti. He is the recipient of numerous honors, including the Bronislaw Malinowski Award and the Margaret Mead Award from the American Anthropological Association, the Outstanding International Physician Nathan Davis Award from the American Medical Association. He holds a John D. and Catherine T. MacArthur Foundation Fellowship, and with his partners in health colleagues, the Hilton Humanitarian Prize. He's a member of the American Academy of Arts and Sciences and the Institute of Medicine, now known as the National Academy of Medicine of the National Academy of Sciences. And he was awarded the 2018 Public Wealth Medal from the National Academy of Sciences. So welcome, Paul. I just wanted to start by just pointing to this slide to open up our conversation. I'll start with a couple of questions to you and then we'll just talk. This is from May 8th article by Derek Jackson. And I was struck by it because it reminded me of something that you wrote in your book, Infections and Inequalities. And Jackson notes that in the Deep South, African Americans made up between 27% and 38% of the populations of South Carolina, Mississippi, Georgia, and Louisiana, but thus far account for between 52% and 58% of coronavirus deaths. In a summary of the data from 38 states and the District of Columbia, the report said that if African Americans had died of COVID-19 at the same rate as white Americans, about 9,000 of the nearly 15,000 Black residents who have died in these states would still be alive. So, on that sobering note, the first question I want to raise is this. In 1989, you published an award-winning book, Infection and Inequalities, The Modern Plagues. And in this book, you gave a really piercing analysis of how, as one reviewer noted, we must tackle the roots of health inequity. And you wrote powerfully about your work on HIV, on multiple drug-resistant tuberculosis in Haiti and other sites around the world. You've had firsthand experience with the Ebola outbreak in Africa. And in the introduction of your book, you wrote, quote, "Finally, this book is lodged as a protest. The inequalities of outcome I describe are, by and large, biological reflections of social fault lines, close quote. And you note that you talked about a patient of yours, Annette Johns, and her death, and you said, quote, "It could and should have been averted. Effective interventions might have ranged from the clinical to the political. To conclude otherwise is to engage wittingly or unwittingly in delusion or obfuscation," close quote. So here we are today, living in a time of yet another plague, COVID-19. So my first question is really kind of a simple one. Knowing what you already know from dealing with past epidemics, what can you explain to us about why individuals from some of the most vulnerable groups in this country, poor, Black and brown people, the elderly in nursing homes, the incarcerated and those who work with them, low-wage workers in all sectors of this country where social distancing is impossible, why are they bearing the largest burden in the wake of this disease?
Oof, that is a lot, Evelynn. You know, this has been the most heartbreaking part of the epidemic, of an epidemic full of, a pandemic full of heartbreaks. And, you know, in hearing what you just read from about someone, I called her Annette Jean, that wasn't her real name, and, you know, in real life. And this, you know, if memory serves on what I changed from in that book in terms of names, this was a young woman who I knew and who was from not too far away from the place where I've been lucky enough to live and work now for close to 40 years in Haiti. And you said that I wrote that there were many interventions that might have made a difference. These range from the political to the clinical. And I should have probably said these include or came to include the political and the clinical. Mm-hmm. Because, you know, if we look at the racialization of the COVID-19 outbreak and look at the, you know, outrageous burdens placed on some communities while others are shielded, and communities, again, I'll go back to that term, then it, you know, for many people, I think it is the most heartbreaking part of it. If we make that a research question just for the sake of this conversation, the one we're having, okay, we would say, well, how does COVID-19 get into the body? How is it racialized? Exactly. Or to use a paradigm that I've heard you use, and I have as well, how does it become embodied? Yes. And it seems to me there are at least two really urgent areas of focus right now, but they could be cast as if they're research problems. One is, how do social disparities, which are after all social by definition and therefore created by humans, how do they put some people at risk of infection, right, while sparing others? Whereas the second set of questions really is only about those already now infected, yes, with this novel coronavirus. Why do some people do so poorly and some people do fine? Because clearly it's not just age. And you know, when we looking to your work, when you look at, you know, how did racial disparities get in the body in the 19th century when we're talking about tuberculosis? You know, what were the ways that those were explained? And I think part of the job here is to take a research question or a question posed hypothetically and then just add very quickly, because people are facing increased risk of infections. And then once infected, they are facing increased risk of poor outcomes. Now, I believe that I could guess with an educated way, I hope in part because of studying this my whole life, and in part because being a practitioner, I know how hard it is for people with chronic comorbid conditions like hypertension, mm-hmm, like diabetes, and I'm not just talking about insulin-dependent diabetes, like diabetes of any sort, how hard it is to stay well. We do have therapies for all of these, exactly, you know, major mental illness or diabetes. We have therapies, but it's not that easy to get them in the body either. Mm-hmm. So I feel like right now we should go on a national crusade, one, to focus on decreasing risk, and two, focusing on disparities of outcome that are so heavily racialized, right? And,
Absolutely.
and I could just take one tiny little example from Johns Hopkins and Baltimore and HIV. I remember in the early days of the epidemic, well before the development of antiretroviral therapy, a number of researchers and clinicians in Baltimore showed shocking racial disparities in outcomes. This is before the development of antiretroviral therapy.
Exactly. Sure. Of
And
course.
they said, are these racial disparities, because they were focused on racial more than gender,
Yes.
because they were so striking, are they due somehow to race, or are they due to the social disparities brought on by racial discrimination? They concluded it was the latter. They addressed these problems, which included, insurance claims, making sure people had access to, for example, prophylaxis against screening pneumonia. And what they showed, and I'm sorry to go on so long, but
No, it's okay. Fine.
what they showed was that you could erase these disparities. And this is, again, before the development of antiretroviral therapy. That's where we are right now with COVID. We don't have specific therapies. We don't have an antiviral that we know works reliably, but we have plenty of non-specific therapy, from oxygen to intravenous fluid to good nursing care, right? We have these things. We can make a difference now, I feel.
So I think that the part about what we can do now is really at the heart of the matter. I mean, we know that what you just described, what I described in the little clip on the slide, are things that are not surprising to us, right? We know this is important and significant. So the issue is, in many respects, what we can do. So you're working with people over in Chelsea, the neighborhood, and here in Massachusetts. Nothing surprising, I would think, for you and your colleagues to know that in a densely populated section of Boston, where there have been many, many people who are living in crowded conditions. Many of the population there have jobs in those sort of essential functions that give them extended exposure to the virus. And so then what do you do about Chelsea?
Well, first of all, having learned a lot about Ebola, Zika, HIV, cholera in Haiti, Peru, Rwanda, Malawi, here in the United States, having learned about some of these things, one thing is we should make sure that we recruit a lot of community health workers for Chelsea, right? Because the community health workers would be the natural living links between households, which are, as you point out, often crowded, and more on that in a second, between households and hospitals, between households and clinics, and even between clinics and hospitals. So the referral function of community health workers, even before we start talking about contact tracing, the community health function is primary. And in the past, what has been the excuse we've used for not having hundreds of thousands of community health workers in this country? Well, it's not sustainable, it's not cost effective, it's not a priority. All the usual excuses, which sometimes people would class as kind of neoliberal when they're used to deny investment in an important public good, like community health workers who could do contact tracing. So one of the first things I would do for Chelsea is get community health workers on the case. And you could say, well, there are community health workers in Chelsea.
There are community health workers in Chelsea.
And, and they need and deserve some support. There are also 350 local public health offices in the state of Massachusetts, which sounds like a lot, but they're overwhelmed. They deserve some support, right? If you look at Navajo Nation, sorry to skip across the country.
Oh, that's okay.
And think about, for decades they've had community health workers, but they have 120 community health workers for a place that is vast, geographically vast, and spreads into states. So I'm just saying, for Chelsea, let's start with community health workers. And then when you have community health workers on the case, then you can do a better community diagnosis and find out, well, do folks in Chelsea have, as we fear, difficulty because of sudden unemployment, difficulty paying the rent, difficulty looking out for grandma, difficulty with childcare, difficulty because, you know, I said rent already, but, you know, basically, are the problems going to be that shockingly different from what we would see in Siberia or rural Haiti or, you know, the answer is no. There's still going to be social problems. They're going to be around things like housing, education, rent, and income. And so I think the things that we can do for folks in Chelsea are a lot like the things we can do for folks anywhere, you know, and that is listen to their material complaints as well as their very legitimate social complaints.
No, I mean, I wouldn't disagree with you at all. But you've also written that, quote, the sick of rural Haiti, urban Peru, sub-Saharan Africa may be invisible to those tallying the victims of modern inequality, but they are, in any sense, casualties of the very same processes that have led to crime and decreased social cohesion here at home, close quote. So what are those processes that have led us to seeing the ways in which, for you to see in any event, connections between the sick of rural Haiti, the urban Peru, and sub-Saharan Africa?
So you warned me you were going to ask me that.
I didn't trick you at all.
I should have been prepared. Well, you know, those are very tough claims to back up, but I think they are made again and again because we can back them up. That is the claim that some of the same processes that have been embodied, again, back to that paradigm, embodied as racial disparities here or epidemics of incarceration or infectious outbreaks inside prisons. I know it sounds extravagant. Well, it doesn't sound extravagant to you, but I understand that it is an extravagant claim. And I believe that there are lots of ways we can back up such claims, and historical research is the best way of doing it. Mm-hmm. And, you know, I would in trying to answer that question, I would dig back, Evelynn, into, you know, the fact that we really never had a founding as a democracy until Reconstruction, and that lasted for about 5 minutes, and then came Jim Crow.
Exactly.
And, I mean, I was born in the era of Jim Crow, and I don't feel that ancient, you know, and so I think, yes, I can describe those processes, and they are reliably about exclusion and the ways in which social inequalities are not only deepened, but generated over time. And so the way to fight back against them is, again, to think about freedom from want and to think about freedom from the insecurities that I already mentioned, the loss of jobs, the loss of housing, the loss of insurance. And, you know, I find that sometimes, maybe not in a classroom all the time, but in public speaking, that people are surprised to learn that serious illness or injury is the #1 cause of destitution in the world in most studies. So, you know, that's why I muster a little bit of optimism that we can use this crisis to address some of these chronic problems.
So one of the things that people are talking a lot about that I want to turn to next is whether or not the United States specifically was adequately prepared to face something like COVID-19. Now, what I want you to sort of reflect upon, so what does preparedness mean when we're talking about the sort of underlying level of structural inequality being such a driver? So when these people will write these very important tomes about what we could have done, having, you know, warehouses of various supplies, PPE, perhaps some research, a research apparatus that was more nimble, all these kinds of things. But how does that relate to a sense of preparedness when what has to be prepared against is a set of structural inequalities?
Ouch, double ouch. You know, the way that you started this discussion, going back to Annette Jean, allowing me to mention the clinical and the political, you know, I think rather than dig myself into a rat hole, I'll stick with that a little bit longer and say, you know, right now, everyone who gets involved, I hope it's not right now that we start hearing these, seeing these, what do you call them? These dignified tomes or tomes by dignified people about what went wrong. I'm sure they're already being written. But we do need clinical and, you know, and I'll just use this cheesy term, programmatic interventions. I mean, after all, you know, I mentioned the history of colonialism indirectly when I was talking about, including settler colonialism. But, you know, there are places like Sierra Leone or, you know, Liberia, Haiti, Malawi, that they've already undergone this intense process of extraction, you know, through colonial rule. And I feel like we've amassed enough goodies over here so that we can be walking and chewing gum at the same time. In other words, we can be doing those clinical interventions and programmatic interventions that will say, okay, ma'am, we know you have diabetes and we know you're not going to be able to go and get your scripts or, you know, fill in the blank. Therefore, in order to protect you, we're going to manage your diabetes well. And then if you do get COVID, et cetera, et cetera, et cetera, those are fundamentally what I meant by clinical and programmatic interventions, right? Yes. At the same time, everyone who is not part of a group where those would be considered only part of the response, then your group isn't big enough, right? So if you're a nurse working in a respiratory unit at a big Boston teaching hospital, I would say if you can just survive the day and take care of those patients, you've done your bit. But you're part of a group that is talking about housing insurance, unemployment, health insurance, a national health insurance program, you know, publicly funded options so that people with Medicaid aren't always left out in the cold, et cetera, et cetera. In other words, if we could collectively be part of a group that is responding to the kind of structural determinants that you outline, I think we'd all be in a better place, right? And I think you know, again, I hope this isn't pathological optimism. I think that's one reason that people are coming back to Partners in Health and saying, hey, how are you addressing both the problem in front of you, even in Massachusetts, and the root problems? Right. And I think that's exactly how we should be addressing one another. Hey, what are you doing to take care of grandma? And what are we doing to make sure that, you know, Uncle Henry doesn't lose his job and his health insurance? Exactly, exactly. So I shouldn't say Uncle Henry, I should say the theoretical Uncle Henry, we don't know. Exactly. So, I mean, I think there are two other pieces of that. One of the things I've been looking at is what was happening in the early 2000s, in the early days when people were really sort of beginning to focus quite seriously on the whole issue of health disparities. And there was a really important conference that happened in 2000, and it said health disparities. I think it was entitled something like Health Disparities Bridging the Gap. And in that introduction to that, the Senate leaders spoke eloquently about the need for a certain kind of political, medical, public health, industry cooperation. They talked about ways we need to be monitoring whether these disparities were narrowing or whether they're widening, and how we should be monitoring them, how we should be looking at data based on race and ethnicity and class. And it all sounds, I'm reading and I'm thinking, this is great. So what happened between 2000 and now? And why are we still commenting on the same things and trying to return to something that many people like yourself and others had delineated quite a while ago? And so the question is,
The critical question, in my view, is what can the scientists and the public health experts and the sociologists and the economists and the physicians and the nurses and the regular citizens do to ensure that we aren't asking the same set of questions 20 years from now, and that we've somehow come to terms with that these being the questions that actually don't need to just be asked, but they need to be answered.
Well, I think one of the things we can do, Evelynn, is to make it embarrassing to have the conversation be so truncated in the future. And again, I don't want to be pathologically optimistic, but in the last 40 years of paying attention to health and social justice matters, I've never seen the conversation as advanced as it has been in the last couple of months. In other words, I've seen more progress in the conversation, the quality of the conversation around structural determinants, for example. I also, so we can make it embarrassing to have a conversation about an emergency that doesn't get into the details of how we build back better, meaning the institutions have to be better and more humane and more just. So we make that embarrassing. You know, I think people, you know, it's hard to be literate and stay literate on these matters. For example, you have these major bailouts, which I welcome. Seems to me a good way to use public monies. But very little of that money has gone to public health at all. So even there, you know, there are so many people that would know much more about these disbursements than I do. But I think a physician and a teacher ought to be literate in that. You know, in other words, even if I were not that interested in public policy, I ought to know where those resources are steered. And I know just enough to be able to say very few of them are going to public health initiatives. And that could easily be changed tomorrow, for example, with the next bill. I think in a third way, in other words, so the first way is make it embarrassing to have such a preliminary, you know, 101 kind of explanation. A second one, know enough about these public measures around COVID to have an opinion about the specifics. And then, you know, looking at, again, your career, your students, our colleagues, literally our colleagues in social medicine, history of medicine, these discussions about, I'll just give stick with our example because I think it's the most important one right now.
Okay.
Racial disparities and COVID. You know, what is the difference between various reductionist forms of explanation? Some of them racist, but some of them racialist.
Yes.
Many of them racialist. And some of them cognitivist. Well, you know, people believe these weird things, so they do these weird things. Some of them culturalists. They often sound a lot like cognitivist explanations. I have obviously favored a number of fairly materialist explanations.
Yes.
But not that are I think what you might expect from a social scientist, an anthropologist. So I think looking at our peers, we should continue and push harder on ourselves and on others to just be more literate in the nature of these explanatory discussions. You know, why do some people get sick and other people don't remain well? Why is the pattern in Atlanta the way it is, or New Orleans, or, you know, the Netherlands? And I think, again, I see more interest in this in the lay public and among my medical friends who are not in our field. I see enough interest in this now that I'm just hoping we'll push that forward as social medicine and people and social history people.
So I think that's laudable, and there are two pieces of it that I would push you on a little bit. The first is the sort of these sort of racialist ideas and even systemic racism itself. How do you turn that into a public health um, uh, high priority to the extent that all of your students over at TH10 and the medical school really understand that that has to be a mandate as part of their work. You get the most committed, and I'm not trying to make a value judgment against other people, but you get highly committed and dedicated and really smart people to come through there. How do we get them to turn away from prioritizing a technocratic or technological answer to these questions and really come to terms with the structural inequality part and be as committed to joining in partnership with the other folks that we've been talking about?
You know, part of it, I think, I mean, you've been struggling with this your professional career, as have I. But part of the you know, when we make something technical and it is technical, and I'll just stick with the COVID example. Like, I'm very interested, as are you, in how space gets laid out and what space becomes safe. And, you know, just to stick with this pedestrian example, you know, of I'm sorry, COVID is not pedestrian, but I mean this very specific material example. How is a virus that's spread in that way, what kind of technocratic interventions and technical interventions would make a difference? If I were working on that, let's say I was a OSHA specialist at the Chan School who is also a pulmonologist or, you know, a clinician. If we had a platform for engagement, we had a way for our technical colleagues to feel like they're involved in a more direct social justice endeavor, then, you know, we should do that. And again, I'll just give an example. There have been a number of public health students, medical students, and medical faculty and staff and administrators of all sorts, you know, sign up to help us with the contact tracing initiative here, right? And it's not that we were saying, hey, we need your public health expertise so much as we're saying, yeah, we understand you want to make a contribution, as do we, in responding. So, you know, that seems like a namby-pamby answer. Like, when you have a technical response to something that is technical, but it's also social, what are the mechanisms by which we engage people in social justice work? And again, I'm just feeling like there's going to be more coming out of this than there was going into it.
Well, I mean, I really hope that there will be more coming out of it than went into it. And I hope this is that transition moment where the many people who care about structural inequalities and how they shape our health outcomes, especially in the midst of a pandemic, will be take that past the moment when we're in crisis, which we are right now.
Can I add one thing that you did add, but I didn't, and I would like to echo you, and that is use the word mandate. And I think we should also remind ourselves that we do need to entrap ourselves into decency with laws and legislation. I mean, again, when you talk about, you know, Reconstruction, Jim Crow, the civil rights movement, in each instance, we are talking about laws that are changed and laws that are undone as well. In the example of what happened at the end of the 19th century, you know, that was clearly to counter other laws. And, you know, I can tell you with some shame that I could get all the way through, you know, medical school in Boston and really not have been able to tell you, like, how Medicare and Medicaid were financed and what they were there for and how healthcare in general was financed. I just didn't know. And I was interested.
Yes.
More interested than most med students. And I still didn't know. So, you know, I just knowing how little I knew about public policy around health and insurance, in spite of my interest and in spite of the fact that I was at a medical school that had all these resources and still does, you know, it just is a reminder that not only do we need to mandate that we do things with more decency, but we have to mandate that we ourselves are involved in that, as you said.
So can you think of one of the moments in the other outbreaks of really kind of these deadly, serious viruses and diseases where it's hard to see what's going to come out the other side? And what makes you, what in those moments, and I'm sure there were many, I certainly remember in your book, AIDS and Accusation, that must have seemed just absolutely overwhelming and had to have given you in some moments a sense of, why am I even trying? But what happens for you, and AIDS and Accusation was a while ago, and you've done many things since then, but you're still at it.
Yeah.
And you're at it in the midst, and you're in the fight right now, right here. And so I think for last week we had a question from some medical students who were forming a group and trying to figure out where they could help out with the current crisis. But can you reflect for them how you keep doing the work and what it is that compels you, even if there are moments when you can't see whether multiple drug-resistant therapies, you're going to be able to make them work in a catastrophic situation?
Well, I also want to be honest that there have been situations that are frightening in a way that is related to the speed at which events unfold. Mm-hmm. So, someone who has a chronic indolent disease like tuberculosis suddenly starts coughing up blood. I think that's what happened to Annette Jean. Mm. And it's terrifying. Or a disease like cholera, where it's just ripping, or Ebola, where they're ripping through a population, that's kind of crumbling in front of you. Yes. That's pretty scary. And I'm sure there are people who feel that way in New York or Wuhan early on, where everything seems to be happening so rapidly. But the answer in all of those, and even with the slow unfurling disease, or a more slowly unfurling disease like HIV, or it's just, this work is made possible by so many other people. And so if you can grow that team and are part of a team, I can't even keep up with what my colleagues are doing, even just looking at COVID in Massachusetts.
Right.
I find out about, just today about, a technical assistance effort they've been involved in for weeks already, and I didn't know about it. You know what I mean? Because it's a big team. Yes. And it's a well-functioning team. Mm-hmm. And when you are frightened or fatigued, as everyone becomes, then you have a big crowd of people, working there with you. And, just this, in the mornings, 6 mornings a week, people have a call in, from across the world: Haiti, Rwanda, Malawi, Lesotho, Russia, Navajo, places, and what could those places possibly have in common? Right. What could they possibly learn from one another that would be pertinent to what's at hand? Well, the one thing that I've learned is, even if they never do learn that kind of lesson, they've learned that they've got each other. Mm-hmm. And it's a very uplifting thing in the middle of this epidemic. And of course, sometimes you will have someone say, well, I remember when this happened to us in the middle of, the Ebola epidemic in Sierra Leone, and blah, 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 blah. That happens too. But I think the real way you keep getting back at it is to work with great people who are very passionate about it.
Okay, that's hopeful. And that's a good way for us to open up the conversation to some of our participants, okay? All right, so I will open up the chat and see what questions there are, and try to, if there are multiple questions about the same set of things, then we'll try to combine them. So the first one is about the this is definitely for you, the efficacy of, and I am not going to say this right, but hydroxychloroquine.
Yeah.
And there were, and the question is, there are several studies that showed it was not effective, but why do you think beliefs in the drug persist?
Yeah, I mean, I'm just going to be guessing. I'm very interested in this, of course. The drug in question is hydroxychloroquine, which is an anti-parasitic and anti-malarial. And I remember very well the first. I'm at the Brigham, and just getting ready for having COVID patients there. And I'm an infectious disease doctor too. I think you may have said that.
Yes.
We were asked, well, what meds should we have on formulary? And of course, since it's a novel disease, the humble answer would be, we don't know.
Mm-hmm.
We know some things about other SARS viruses, other coronaviruses, and other SARS viruses. There are broad spectrum antiviral medications, just like there are broad spectrum antibacterial medications. So all this to say is I had nothing against chloroquine or hydroxychloroquine. And I even remember calling up in Haiti, my colleagues in Haiti, and saying, do we have hydroxychloroquine and another antibiotic that President Trump was mentioning? Do we have those on hand? Because there's no reason, there's no reason to assume anything at all about them. And in the 2 months since then, that those drugs have been used a great deal. And you can't say that about a vaccine candidate, right? Because the vaccine candidates haven't been used a great deal, but those drugs have. And my understanding is there's not any strong evidence. And the question was, why is there so much persistent belief about this? The only thing that I can think of is that very powerful people continue to this day, including today, to trumpet this as at least a therapy that has proven results, and it's not. So usually snake oil, if it's going to be successful, has powerful marketing behind it of one sort or another. And I mean, again, you'd know more about this probably than I do, but I just assume that it's because it's of ties to powerful spokespeople. Why President Trump has settled on this, I have no idea.
No, I don't either. But it also speaks to, how the desire, I think, of people to, in the face of the fear that such a pandemic raises, no matter where you are. And if there's something that works, then people will grasp at straws. And then if there's a powerful marketing apparatus behind it, it'll begin to more and more seem to be something that should not be dismissed. But I mean, of course, we want to push the science, and the science says not a good idea, then that's the end of the story. But it's not going to stop that desire for an answer.
I should have said that first, though.
Yeah.
I should have said that first because God knows I wanted it to be true.
We all want something to be true.
We need hope.
Another question is, what are your thoughts on universal access to treatment and a vaccine once we get one? Because that's going to be the next question. Yeah. Now, I mean, there's a full court press by all kinds of groups to figure out something, and it may move very fast. I mean, the scientific community is collaborating and putting out early results so people can move quickly. And then once we move quickly, then we have a whole other set of questions.
See, I have a little smile on my face now, and not because anything good has happened yet, but this is an example. The question was, it started with universal health coverage. Was that the term, or care, whatever?
The question started with, wait a minute, I may have lost it. Hold on.
Something with the U word.
Universal access. Once we have, yeah, right.
So here is something that we have been clamoring for as if it were even a specific thing, universal access, but I know exactly what you meant beyond the vaccine. There's also a movement for universal access to public goods, including public health insurance. And so the smile that was playing over my features is because we've been clamoring for this for decades. And that would be true whether it was an anti-TB medication or, a diuretic that's effective and cheap, doesn't matter. And so will we have a public clamor for widespread access to that vaccine, not based on the ability to pay? I think we will. I think we'll have demonstrations in the streets if necessary. And I think that'll happen all over the world. So I would not want to be the person trying to keep an effective, safe vaccine hidden under a bushel basket, because I don't think that's going to be possible.
Right.
And it makes me smile with a little bit of anticipation, because that's a struggle that we would like to have.
No, we all wanted to. We all, when it happens, and it looks like we'll be able to get a vaccine in a sense more rapidly than in the traditional methods, because people are innovating and working very hard in many places. So there is some sign of hope there. Another question is about how you see the role of environmental health with respect to health disparities work. Is there something in that field that should be also made more front and center as we think about the kinds of collaborations we need to kind of address what's happening?
Evelynn, you cut out for a second. Which field was it?
Environmental health.
Yeah.
Yes.
Well, I was drawing on just that kind of an example when I was talking about the engineering of room air. These are people who come to these problems from environmental sciences, environmental studies. And, back to your earlier point, Evelynn, I think of that both in terms of the natural environment and the built environment. And that we need very much to bring, as much as it is possible, and it is possible, to bring those communities together as part of that's the thing about environmental justice. It needs to be a subset of social justice, not the parent institution of social justice. So, if you look at the environmental movement in the past, it has often been an elite movement, not a populist movement. And, really it needs to become a social justice movement so that it can include these social justice and structural arguments that you're making.
So I think this follows right along with that. Do you think this crisis is going to be used as a gateway for us to get universal health care in the United States?
Well,
the
one thing we can answer is, do you think it's worth fighting the fight to try and make this part of the process? And I think a lot of people are not willing to give up without a fight.
No, I think without a fight, I think is really sort of maybe part and parcel of what we've been talking about. It's not as if we haven't been working on this issue of universal health care in the United States for a very long time. Contentious discussions that rise, and there's a lot of heat and very little light, then they die away and everybody struggles along. But this has really showed people how much it means that if your healthcare is tied to employment and you can't work right now, then you can't get the healthcare you need. And if this is not a clear example of a system that needs to change, I don't know what could possibly be worse or better to explore for people to see. And so, as you just said about, making universal access to the vaccines that may be coming along, this is the same, to me, it reflects the same kind of, might be the same kind of spark for a conversation that we've, as I said, it rises, it falls, but maybe it's the time that it will actually, some serious action will be behind it. Because people are suffering right now in ways that it's not an abstract conversation anymore.
No, it's very visible.
Absolutely. The last question we have time for, Let me see. So I guess one question is about in places where there are real under-resourced, and you've worked in many of those kind of places. So what do you have to do if getting the necessary resources to move forward, or if that door is closed, then what do you do?
Keep banging down doors. You know, I think, if they're doors, they were built by fellow humans, and they can be dismantled. It is a reflection, I'm sure, of privilege to make an argument like that, right? That we just have to dismantle the door or break it down. At the same time, it's like there have been people working for all these decades on universal access to care, as you're just saying, in this country. So that, again, that's people fighting to open doors. And, there's no door that can be closed permanently on this whole debate about equity and resource distribution. I have a hard time believing we can't keep opening doors, but I understand the privilege inherent in that, making the argument.
So one of the other things that you've done, you've worked with a lot of international health organizations, and of course, in the midst of this pandemic we're in the US, there's been some criticisms of international organizations. You clearly have a lot of faith in them, and you work with them every day. And so can you say something about what you see as the value of those collaborations and the value of at this point in time having it's such that you guys can have a 6 a.m. conversation and talk and share information and share ideas?
Yeah. Well, I think a lot of the criticisms of international non-governmental organizations are warranted. Mm. And it's not a judgment call on those who create or constitute them. But I'm just saying, in terms of our performance, it is also contingent and needs to be assessed. So I just want to start by saying that I think this is a good thing that we're being critical of international organizations. A second is, if we go back to the first order questions that you were asking earlier, and we think about freedom from want and the basic social and economic rights, like the right to health care, mm-hmm. that we're fighting for, those are conferred not by international organizations, but by states. Mm-hmm. So what we have tried to do as Partners in Health is to work with ministries of health, which means public health authorities. We don't call them ministries of health here. It would be the same thing we're doing with Massachusetts, working with the local health authorities. If we can find a way to have private, non-governmental organizations help a government bureaucracy, like one trying to respond to COVID-19, mm-hmm. that's a very good thing. Mm-hmm. That adds up to more than the sum of our parts. But what we found is that in many places in the world, perhaps most of the ones in which I've worked, non-government organizations are not propping up public health authorities. They're setting up rivalrous or mm-hmm. parallel systems. Mm-hmm. So hence the chronic fatigue of many public authorities in many parts of the world, and particularly I think in parts of Africa and Latin America. Mm-hmm. So A, it's a healthy critique. B, we should listen to it. C, we can work with public health authorities in ways that only make us better as international organizations.
Okay.
And then D,
do
it that way if it's ever going to add up to being a right, like the right to healthcare.
Okay. So we're running out of time. I give you a chance to say one last word to the participants about how we should go with courage and fortitude with our allies in the face of this.
Well, I agree with every word of that. I also think We will be facing some real challenges that are born of something good, like a vaccine, some new therapeutics, maybe even more promptly. Therefore, we're going to face all of these structural problems again and again, not just in terms of the way risk is embodied, but the way in which we try to disembody risk, like with the vaccine.
Mhm.
So we need to stay strong, fight on, and use all of our scholarly attention that we can to address these challenges.
Well, I completely agree. And I thank you for taking time out of your busy day on the front lines for sure to have this conversation with me. I really appreciate it. And to our participants, thank you for holding on, hanging in on the conversation, I should say. And then just to say that next week we'll be talking about lessons we can draw from HIV work over the last 30 some odd years for thinking about what's happening today. So thank you so much, Paul. I really enjoyed it. And I appreciate that you were here with us today.
Thank you, and thank everybody listening. I'm drawing a lot of positive energy from this, so thank you very much, Evelynn.
Thank you. And thank everybody. See you next week. Bye.
Bye-bye.